Good evening, everybody. I'm Kelly Cleary. I am Content and Programming Manager here at Best Doctors, and I'm also your host this evening. I'm very excited because we're joined by Leana Wen and Josh Kosowsky, two emergency medicine doctors and two authors who've recently published a book, When Doctors Don't Listen. Before I introduce them, however, I'd like to say a couple of words about Best Doctors and how we're also helping to improve communication between doctors and their patients. So, as you may already know, Best Doctors was founded in 1989, by two Harvard Medical School professors. Their goal was to help patients and treating physicians identify right diagnosis and treatment. And we do that through an in-depth second opinion process. The way this works is that a patient contacts us and comes to us with requesting a second opinion. We gather all of their medical history and their imaging, and we give it to a team of internal doctors who compile a clinical summary. We then take this clinical summary and we give it to a Best Doctors expert who uses it to write a case analysis, his second opinion. Once we have this document, we then give that back to the treating physician and to the patient so that they can use it as a tool to discuss together the patient's care. We've actually recently taken this process online through the development of an online platform where doctors can work together on difficult cases, and we're very excited about that. Our Best Doctors, if you don't know, are elected through an impartial Gallup-certified poll. If you're a Best Doctor and you're listening tonight and you're interested in this case consultation, you'd like to consult on some of these cases as I just described, or if you're a treating physician and you'd like to get one of these consultations for your patient, see if they're eligible, you can request more information about both of those things in a survey at the end of this webinar. So I'll pull that up at the end and you can indicate that you're interested in more information. But for now, I'm very happy to introduce Leana and Josh. Leana Wen is an emergency medicine physician at Brigham and Women's and Massachusetts General here in Boston. She's a clinical fellow at Harvard Medical School, and she's also a former Rhodes Scholar. Josh Kosowsky is the Clinical Director of Emergency Medicine, and he is the Vice Chair of Clinical Affairs at Brigham, and he's also an Assistant Professor of Emergency Medicine at Harvard Medical School. They have, as I was saying earlier, recently released a book, When Doctors Don't Listen. I've pulled up a little bit of information about it here on the screen. The book gives patients tips on communicating with their doctor, and it helps them become active participants and even advocates in their own care. But we're excited tonight to have Leana and Josh on the line because they are going to be giving tips on how doctors can encourage this kind of dialogue between themselves and their patients. So Leana and Josh, thanks for joining us tonight.
Thank you for having us.
By the way, I just want to point out that if you have questions, any of you listening tonight, if you have questions for the panelists, please feel free to submit them through the question and answer module that is on the bottom right of your screen. As you can see, the slide that I've pulled up here, it kind of shows you where it is. So that's the best place to ask questions, and I will be leaving that up for a while in case you do have questions. Now, we want to talk tonight, we want doctors on the call to be able to have actionable steps that they can take back to their practice to really help them understand how to better communicate with their patients about, their diagnosis and their care. Leana, you've mentioned to me before the importance of a good history taking, and I'd like to hear, how can doctors encourage patients to be prepared to give a complete and robust medical history?
So first of all, Kelly, thank you so much for having us here to talk about better patient-physician communication. So Josh and I wrote When Doctors Don't Listen mainly for patients to help guide them to be more active in forming the partnership between them and their doctors. But the same principles apply for the doctor as well. And so in our book, we talk about something called the 8 pillars to better diagnosis. And the number one pillar that we have for patients is telling a good story. And the same applies for the doctor, too, to listen to that story and help the patient tell a better story. The reason this is important, we all know as physicians that the history is absolutely critical. This bears out in studies too. We know that 80% of diagnoses, 80% of diagnoses can be made just based on the history alone. That's better than any test or a combination of tests that we have out there. And that's why it's so important for us to be able to get that story from our patients. So here are a couple of tips that would help. The first is to think about the history and not just in terms of symptoms. The history should be a story. And you can imagine that if you haven't seen an old friend for a while, that you'd be asking your old friend, how are you? How have things been? Open-ended questions. But if instead you asked closed-ended questions such as, are you married? Are you employed? Did you finish college? That wouldn't really yield an answer. And the same thing when it comes to patient care as well. We encourage asking open-ended questions, asking how and why, and not necessarily just these yes, no, closed-ended questions. The other is to really allow patients to talk. The second tip is to allow patients to talk. Studies have also shown that doctors will interrupt patients in something like 10 seconds after they begin talking about their history. And so that really eliminates the doctor-patient communication if the patient doesn't even feel like they can be listened to in the first place, and therefore doesn't feel that they can trust anything else the doctor is saying after. And so asking open-ended questions and also allowing the time for that history to be taken, I'd say are the two most important things to facilitating that interaction between doctor and patient.
Very good. Josh, do you have anything you'd like to add?
Sure. As physicians, we've all been there, and we know what it's like to have the difficult historian or the poor historian. And in large part, our book is designed to help more patients become good historians. As Leana said, how to tell a story that has a beginning, a middle, and an end that has some relevance to the reasons why they're actually coming to see you. But it doesn't always work, and there's some tips that you can do as a physician for the patient who you might term the poor historian. Number one is to give them a chance to actually be a good historian. If we were interrupted every time we got off to a rough start, we wouldn't get very far either. And remember that many patients who haven't read a book like ours haven't practiced their history before. So the fact that they get distracted or waylaid, that can be something that with practice they'll get better at, and you can help them practice it, even in your office. Another challenge, but also an opportunity, is using the medical record as you're going through it in your mind, not so much as a checklist of items that you have to get done before the patient can leave, but as a way to remind you about the really important parts of the history. So rather than going down a list, it can be tempting, especially with electronic medical records, to just tick off the boxes. Rather than do that, keep the medical record in the back of your mind as you're listening to their story, and just make sure that they've hit the key points. And then you can go back if it turns out they haven't covered some element of their past medical history, they haven't talked about the medications. You can go back and do that. I think where doctors run into trouble is where they immediately jump in with their list of questions, their review systems, and that can not only does it cut the patient off, it also becomes intimidating to the patient who's now on the defensive and feels like they're on the witness stand having to give you lots of answers, and it chills them from wanting to go ahead and tell their story the way they intended.
Josh, another tip that I've heard from y'all is the importance of focusing on a diagnosis at the end of the visit, of the patient visit. Can you talk a little bit more on that, expand on that?
Sure. This is another one of our so-called pillars to better diagnosis. We emphasize to patients that they shouldn't leave a doctor's office or any encounter with a physician without some sense of where the diagnosis is. And we emphasize to patients that diagnoses aren't always black and white. There may not be a definitive diagnosis at the end of the visit. In fact, I might argue that most of the time you don't have a definitive diagnosis, but you certainly have a working diagnosis, or at least a working differential, that patients really should be involved in understanding and working towards with the doctor. Now, we encourage patients to actually ask questions that will demonstrate that they want to be involved, but I think doctors have a role as well in bringing up the concept of diagnosis, which frankly can be a scary word for patients, but bringing up the notion that we're working towards trying to figure out what you have, and being honest with patients when we don't know for certain what the diagnosis is, but allow them entry into the way we're thinking about their case so that they can have some appreciation of what a differential diagnosis might be and what the working diagnosis is going to be when they leave your office.
Leana, I'd love to hear your perspective on that.
I mean, I certainly agree with Josh that a diagnosis is critical. You know, we as physicians, we know that it's important for patients to get a diagnosis, but patients know this too. To know what they have, that's the beginning of the healing process, right? To know what you have, then you're able to know what is the natural history, what should you come to expect from this disease, what are the things that you can do to treat it, what are the red flags to watch out for. And so that's why, you know, a lot of medical training, it teaches us that we have to be certain. You know, when we are in medical school, we learn that we can't be wrong. We can't say, I don't know. That's not an acceptable answer. And so I think so many of us who are physicians don't think that we can share the answers with our patients until we're absolutely sure. Or, you know, we just don't want to say. Let's say and patients often hear, well, I don't know what you have, but let's do some tests and then let's talk. But then patients don't know while they're waiting for these tests what it is they have or what it is they could have. And that adds to more anxiety, more anguish, and just more confusion overall. So why not tell our patients, look, I don't know exactly what you have at the moment, but here are the 3 things that I'm thinking, and here are the reasons why I want to do these tests to narrow down which of these 3 diagnoses it is. And then maybe it's none of these 3, in which case this is what we have to do to start over and talking about things. I mean, this is what's going through our heads. Doctors think about this sort of stuff. This is what we're trained to do. So if we're trained to come up with a diagnosis, if we're trained to come up with a differential diagnosis, working diagnosis, definitive diagnosis, if we're trained in this way, why not also share it with our patients? In my discussions with patients and in interviews for our book, When Doctors Don't Listen, that's certainly something that's come up over and over again that our patients want to know. There's a study done, too, that asked patients, because some people think, well, maybe patients don't really want to know, and maybe we as physicians are telling them that they should know stuff. And I think the study was something like only 4% of patients really don't want to be partners in their care. Mm-hmm. So that really behooves us, I think, as medical professionals to involve our patients, especially when it comes to such a critical part in their care, which is their diagnosis.
You touched on something there that I just wanted to tease out a little bit more. When you were talking to patients, what kind of things did they feel weren't communicated to them besides maybe a diagnosis? And what did they walk away feeling from their visit? I should have asked maybe, or I should have been explained this scenario a little bit more, and I don't know. I'm walking away from my visit, and I don't know what they're talking about.
I mean, I'm sure many.
The number one concern that patients express when they're dissatisfied is that the doctor or the provider didn't seem to reflect their concerns. And whether that's that they perceive that the doctor wasn't listening to begin with, or maybe the doctor did listen but dismissed their concern as somehow being trivial, and then went off in some other direction that really didn't make sense to the patient. So this really involves both of those 2 pillars. It involves listening for their story and validating the concern the patient has, but it also means that the patients need to understand what our concerns are. So when we're thinking about a workup for a particular diagnosis, this or that test, we need to explain to our patients why it is that we're concerned so that they understand how their concerns and our concerns are aligned.
Okay. Leana, did you want to add anything to that? Or
just that we have to really ask for whether there are questions. I mean, so many patients will say, well, I wanted to ask about this. So one of the reasons that I wrote this book was my mother was misdiagnosed for over a year before she was finally diagnosed with metastatic cancer. And every time she went to her doctor, she felt like there were things that she wanted to address, but then the doctor said, any questions, but was already halfway out the door when he was asking her questions. I mean, I know that doctors are busy. In the emergency department, we're very busy and we're very pressed for time and very pressured when it comes to time. But as Josh was saying, really showing our patients that we care, really showing them that we're paying attention to what they're most concerned about is critical to their healing as well.
Leana, a little bit of a shift in topic. You have talked before with me about rational testing and also shared decision making. And I know that these two topics are covered in your book, and I also know that they're getting a lot of press recently. Let's start with rational testing. How can doctors foster this culture of rational testing in their practice and with their patients?
It's such a difficult issue, and you're right that this is an issue, shared decision-making, testing, that's come into the forefront these days. Finally, people are recognizing that more care isn't necessarily better care and that our healthcare costs are out of control. We know that 30% of medical care is waste, which is crazy in a country where we're already spending way too much money on healthcare. No matter what side of the political party we're on, right? Everybody agrees that our healthcare system is broken and that the costs are getting out of control, and that one way to tune that back is through cutting unnecessary testing. Now, there are some great groups out there choosing wisely for example, cost of care. These groups are trying to educate physicians about rational testing. But we also have to partner with our patients in this too, because it's our patients at the end of the day who suffer the consequences when it comes to their wallet, but when it comes to their bodies as well. I'm sure that all of you watching this will know that there is a significant consequence to getting too much testing. There are unnecessary side effects. You get excess radiation, you get kidney damage, you get infections, the whole gamut from whatever. But also you get false positives that lead then to further testing for things that may have never needed to be worked up in the first place. And so going back to the shared decision-making piece of this too, now that patients are becoming more aware of the consequences of testing, we need to also involve them in that process of thinking through it. Traditionally, shared decision-making has always been about treatment. If you're going to have surgery, of course you would be asking about what is the side effect of this? Do I really need this test, or do I really need the surgery? How dangerous is it? Well, why not have the patient also ask about this for testing? And why not have the provider have a conversation with our patients about it? We always hear about the fear of malpractice and defensive medicine, which can, in large part, be mitigated by better communication and this shared responsibility and shared decision-making between you and your patient.
Josh, what about you? I mean, how can doctors encourage this environment of a shared decision-making process in their practice?
Well, I think like everything else, as physicians, we need to exercise judgment and make individualized decisions along with our patients. And I think one of the mistakes you could make is to take so-called evidence-based medicine as it applies to testing and apply that in a unthinking way as a cookbook approach to all patients. Now, there's certainly a role for some of these guidelines, and in our mind, that role is to sort of set a ceiling on tests. So if you, in your mind, if you think through a case and you understand what the guidelines say, and let's say, for example, a patient with acute back pain, and you're familiar with the guidelines that tell you you don't need to get an MRI, well, they're probably correct, and in most cases, you're not going to need to get an MRI. But I think where doctors sometimes get it wrong is that they think that just because a patient meets the criteria for a test, that they absolutely have to have that test. In some ways, that can actually lead to more testing. And so what you really need to do when faced with an individual patient, just think through for them, and returning to the back pain case, for example, although they may technically meet some criteria for an MRI, for example, and I guess the good news is that if it meets that criteria, maybe you're more likely to get reimbursed. But thinking about it really from the doctor-patient perspective, it may be that that test really won't have any value for the patient if, for example, the only items in your differential diagnosis are all the types of conditions that you're going to manage conservatively anyway, and you're not really thinking about surgery for this patient. So in the same way that you would think about treatment options, it's important to think through for your patient and with your patient, what are going to be the repercussions? Yes, sure, we could get this MRI. It may even be paid for. It may even be evidence-based. But is it really going to matter if we demonstrate that you do, in fact, have this herniated disc that we think you have? Is it something that we're going to really go on to get surgery for or not? And if the answer is no, then why are we getting the test?
Right. Well, we've got some questions here from the audience, and the first one that I'd like to ask, and it's kind of looping back to the first topic that we talked about, but what this doctor asked, what tips and advice do you have for making the history intake, the H&P process, more time efficient using the electronic medical records? Do you have anything you'd like to say about that?
So we touched on this briefly, and there's no question it's a challenge, and it's getting more and more challenging as the requirements for documentation seem to mount. But it's important in your mind to separate out the work you have to do for documentation from the actual work you do to make a diagnosis. They're not the same thing. And you can do excellent documentation, be very efficient at it, and be a poor diagnostician, and vice versa. So at least in your mind, I think it's helpful to think about those as separate tasks. It may be that you can multitask and do them at the same time, but the important thing is to let your patient tell his or her story. Ask the open-ended questions that you need to. And then at the end, if you have to come back because there's some gaps you need to fill in, whether it's in order to make the diagnosis or simply to dot all the I's and cross all the T's in order to demonstrate that you actually did what you said you did, view that as something separate and apart from the actual work of diagnosis.
It is really hard. When Josh and I were first writing this book, I went to interview a number of patients about kind of their concerns with the medical system, and one of the things that I heard over and over again is how patients nowadays feel like there's a computer between them and their doctor. And that's something that is a reality of our healthcare system. I mean, we have so much documentation, and we have so many checklists of things that have to be checked off just to get reimbursed and so forth. And so that is a significant issue. But there are ways, I think, to get past that computer in a way so that you're aiming for efficiency, but you're still aiming for that human connection. And so we also have to, not give the appearance that we're treating the computer, because the computer is technically in between us and the patient. And so I think this is going to be an increasing challenge as we go through our medical practice as well.
Okay. Thanks, Leana and Josh. And I'll go ahead and just start with you again, Leana, for this next one. How can a doctor continue this patient engagement, and encouraging this patient engagement during the treatment? So they've been into your office and you've come to a diagnosis together. How do you keep the momentum going?
It has to do with partnership. That is the key to this approach that Josh and I are talking about for When Doctors Don't Listen. Patients now feel disconnected from their own medical care and from doctors. I mean, they see so many different doctors. They see a specialist for this, a specialist for that. Their same doctor doesn't take care of them in the ER, in the hospital. That's a function of our medical system, and obviously there's still some doctors that practice differently, but a lot of patients just feel like they're disconnected. And so building that connection with your patient and guiding them through their diagnosis is what will then continue on to the treatment process. I mean, this is only the beginning of the conversation, but it really has to start with listening to your patient, making sure that your patient trusts you, and going through the diagnosis together, getting the treatment together will then follow naturally as a progression of that.
Thanks. Josh, anything to add?
I think that's right. It's really important to get started on the right foot. I think once you have that relationship, as Leana mentioned, it's easier to keep it going. And that's not to say that sometimes you don't get off on the wrong foot, or the relationship has its potholes along the way. But I think if you come back to the fact that patients want to be heard, they want to be validated, whether it's the first visit or the 10th visit, if that's where you start from, it's likely to be successful.
Thanks, Josh. And I guess finally, in kind of moving, to progressively and logically from that, how do you motivate the unmotivated patient? I mean, I think it's true that some patients are not sure how to be involved in their care, and maybe that is a completely new concept to them. How do you create that desire to be involved in their own care?
Well, we emphasize that in order to be a good doctor, you have to have a good patient, and vice versa. So it really is symbiotic. It's hard to have only one active participant in this diagnostic journey. I think for some patients, it's letting them know how important they are to the process. Unfortunately, I think there's a population of patients out there who've been preconditioned to think that their input doesn't matter, that it really is all about the doctor ordering a bunch of tests and doing things to them and for them. And so there's an opportunity to re-educate patients, and that's what this book is about, but I think doctors can do the same, about how important it really is for me to hear from you about what your concerns are, what your symptoms are, because if I don't hear them from you, it's going to be really hard for me to help you. Delivering that message not in a way that sounds overbearing or punitive, but really emphasize to them that to the extent that our role is to try to help patients, we need their help.
I found that three groups of patients that we generally speak to. The patients, number one, the patients who are very empowered and very much in control of their care already. They don't really need our help to convince them to be partners. Another group that thinks this is a good idea but don't know how to do it, and then another group that have something wrong with their medical care, but they don't know what to do. And so we emphasize in When Doctors Don't Listen that it has to start with today. You can't just wait until you're really sick or your loved one is in distress to start practicing a partnership approach to care. You have to start today when you're not so sick, when you can just practice this at a routine appointment. And that's why it's so important for doctors to also practice this in the routine doctor's office appointment to encourage patients to be partners in this process.
So I know that this book, and as we've mentioned, When Doctors Don't Listen, is patient-facing. But just from both of you, I'd like to hear, and Leana, we'll start with you, at a high level, what can a doctor learn from some of the topics that you cover in this book? What are they going to take away, and what would you stress is really important for them to know?
How doctors communicate and what our patients think of us is becoming more and more important. So much of our reimbursement now is based on patient satisfaction, and the communication between patient and doctor is something that now medical schools are beginning to teach more, but is such an important metric for us, and so important. I mean, just based on common sense that this is such an important thing for us. And so our book is aimed at patients to show patients what they can do to partner in their care. But they're partnering with someone, and that someone is you. And so that's why our book is equally as important for doctors and nurses and other healthcare providers to read so that they can partner with their patients. Or you can partner with their patients to make sure your stories are told, you get your diagnosis, and you really talk through your patients through all the decisions that have to be made towards your patient's care.
Josh, anything you'd like to add?
We wrote a book for patients, but we've been really pleasantly surprised by the reaction that we're getting from doctors and other health professionals. I think there is something in there for everyone. We actually have a chapter in the book specifically for people in the health field. But as Leana points out, in order for doctors to be really good doctors, we need to understand where our patients are coming from. And I think a book like this offers that perspective.
Great. Well, as you can see, you can learn more about this book at whendoctorsdon'tlisten.com. And here on the screen in front of you, you'll see a post-event survey. Any information that we discussed during the webinar, you can request here by using the survey. And I'd also like to mention that next Wednesday, March 27th, at the same time, 8 p.m., we will have another webinar, this time featuring Dr. Martin Samuels and a physician panel, and they will be talking about their own mistakes that they've made in diagnosing patients who present with symptoms of chest pain. So there's information also on registering for this webinar, and you can request that by taking this survey, as well as some of the information that we discussed here tonight. So, Josh and Leana, thank you for being here.
Thank you.
Thank you.
This has been fantastic, and we are at the bottom of the hour, so I want to be respectful of everyone's time tonight. I'd like to thank all the attendees for coming. This has been great, and we hope to see you next week. Have a good night.